So with that, I'd like to invite Dr. Liz Kranz. Dr. Kranz is an associate professor of obstetrics and gynecology and reproductive medicine at the University of Pittsburgh and the director of the Pregnancy and Women's Recovery Center at McGee Women's Hospital, and has been actively researching and publishing in this area for quite a long time. So Dr. Kranz, over to you, and thank you so much for joining us today.
Absolutely, I am thrilled to be here. Can you just confirm that you guys can see my screen okay?
Yes, I can see it, and now it's in slide presenter, which is great. Thank you.
Yeah, you do have the right, because I have two screens. Okay. All right, so I'm excited to talk to everyone today about this incredibly important issue. So when we refer to concepts like the hepatitis C care cascade, what are we really talking about? So in pregnancy or the perinatal period, that starts with screening. And in the United States, we have now, fortunately, gone to a universal screening for hepatitis C approach, which is relatively recent. So all pregnant individuals, and especially those with substance or opioid use disorder, should be screened for hepatitis C. And that really is a hepatitis C antibody with a reflex to an RNA to understand evidence of chronic infection. However, there are currently no FDA-approved medications for the treatment of chronic Hep C in pregnancy, which has been mentioned already in this webinar, which creates barriers to the receipt of treatment. So what happens is we screen and evaluate patients for hepatitis during the perinatal period, which is a time of really intense healthcare engagement due to a variety of reasons, including expanded healthcare insurance coverage. But we have to refer them to treatment in the postpartum period. And so what happens is you have this inherent discordance between the diagnostic process and the receipt of treatment, which creates many barriers that I'm going to discuss and illustrate it through some of the research that we have done with my colleagues, Dr. Marian Jarlinski and Dr. Catherine Chappell. So we wanted to look at the population level to see how this linkage of care, or this care cascade between screening, evaluation, and treatment, how's that been going with the current landscape of treatment. So we looked at a multi-state Medicaid data research network, which was something put together by my colleagues here at the University of Pittsburgh to, again, try to understand what happens in this care cascade between the diagnostic process and the receipt of treatment. So the research network is composed of Medicaid administrative healthcare data, which is in the United States, our publicly funded insurance program that is delivered through the states. And we combined healthcare data from 6 states in the United States. That's Delaware, Kentucky, North Carolina, Pennsylvania, and West Virginia. And what's important about some of these states is, especially Kentucky, Pennsylvania, and West Virginia, there's a very high prevalence of substance use related disorders within this particular geographic region in the US. And so because we know hepatitis C is now predominantly acquired and transferred through injection or intravenous drug use, having a high prevalence of this particular population was key to our analysis. So we looked exclusively at the population of individuals who had opioid use disorder, again, one of the highest risk factors for the acquisition of hepatitis C. So this was a subset of the general population, again, only substance using individuals and opioid use disorder. They had to have a live or stillbirth delivery after 24 weeks gestation. And the time period we looked at was between 2016 and 2019. So in order to be able to capture if they had been screened or evaluated in pregnancy, part of our inclusion criteria is they had to be enrolled in Medicaid for at least 6 months during pregnancy so that we had time to observe the ability to be screened for hepatitis. So, and we followed women through 60 days after delivery. So all women, when they received Medicaid eligibility or Medicaid insurance due to their pregnancy, are mandated under federal law to be followed or to be insured for 60 days after delivery. So that's a minimum requirement for the entire population that we evaluated. However, a subgroup of women remain continuously enrolled in Medicaid for 6 months after delivery. So we were able to look at a subset of the total population of our sample to extend beyond that 60-day period to 6 months to see if we could pick up more incidences of treatment in the postpartum period. And again, this is a very US centric, but in the United States, this occurred before our more recent 1-year postpartum expansion of Medicaid delivery. The data is from, you could receive Medicaid after the 60 days if you had income eligibility for Medicaid related on your household income. So that's how some of these individuals were able to maintain Medicaid coverage for 6 months. And that would be in states that had ACA era Medicaid expansion, which were all the 6 states with the exception, or 5 states with the exception of North Carolina. And like I said, this was postpartum coverage expansions, which is really recent to this particular year. So what was our final analytic? We had over 23,000 patients that we were able to look at who had opioid use disorder. And then 83% of those were actually remained continuously enrolled for 6 months after delivery. So a very large sample size, and truly the ability to look at this on the population level. All right, so a little bit about administrative data here, just to help to put this in context. So how do we define hepatitis C testing? So that was the presence of any procedure codes in the healthcare administrative data for an antibody or RNA testing between the estimated date of conception and the date of delivery. Again, minimum of 6 months enrollment, but we tried to look through the entire pregnancy period. And if they had evidence of these tests in the data, we counted them as having been quote unquote tested during pregnancy. Similarly, we looked from a diagnostic perspective, whether there was presence of the diagnosis or evidence of the disease, and this was a yes/no binary variable. So that would include any ICD-10 diagnosis code for chronic or acute hepatitis C infection, again, between the pregnancy period. And importantly, so that one of the primary limitations of administrative data is, which is really the only way to look at the population level, is we don't have lab results. So we have codes that indicate that testing occurred. So we had to go to diagnosis codes to make the assumption about whether or not somebody had the infection versus the results of the laboratory test. So there's some inherent limitations in that approach, but that is what we have, but it's important to mention that. And we tried to look at the timing of these testing codes and the diagnostic codes to try to, again, really create a longitudinal relationship between the testing process and the diagnostic process, because clearly several patients may come into the care cascade already having the diagnosis prior to pregnancy, although it's extremely common to get that initial diagnosis due to that healthcare engagement in the pregnancy period. So postpartum follow-up, we looked at a follow-up visit after delivery, which was also a binary measure of it happened or it didn't. And that was either a visit with somebody whose subspecialty was related to hepatitis, like hepatology, infectious disease, or gastroenterology, or we counted that as a visit with a primary care provider where hepatitis C was a primary diagnosis code recorded for the visit. So that's how we defined whether or not patients followed up for a hepatitis C specific reason versus a variety of other reasons that clearly can occur in the postpartum period. And then finally, postpartum treatment receipt. So not only did they receive a visit, but did they initiate treatment in that postpartum period? So this is where we looked at pharmacy data to see if there were any outpatient prescription fills during either the 60-day to 6-month window of any medication that could be used to treat hepatitis C, all the way for the interferon regimens, all the way to the DDA. So this was anything that could have been used to treat chronic infection. Then clearly we had adjustment in the analysis for a variety of patient level variables that could be associated with either substance use or opioid use disorder or hepatitis C infection. So what did this population look like? I think this is important to kind of review the demographics of our sample. So the vast majority of individuals were white, and then we had 7% Black and 2% Hispanic. 55% of individuals were taking a medication for opioid use disorder during pregnancy. 60% had a co-occurring non-OUD substance use disorder, like a stimulant use disorder or an alcohol use disorder. 5% had cirrhosis or liver disease, again, based on diagnostic coding criteria. And 5% had an infectious sequela of injection drug use versus diagnostic criteria, and that would be something like endocarditis or sepsis. So here is the care cascade. So this was a multi-state analysis. So our data was presented by individual states to look at significant between state variability, but then we also had an aggregate overall prevalence estimate. And I just wanted to just start with these raw prevalences to start the discussion. So if you orient yourself to the left side of the screen, this is the percent of patients who received a hepatitis C test. Again, this was an antibody and RNA test during pregnancy. And if you look from A through L, which are the 6 states we evaluated, there is some variability, so that the highest prevalent states would have 79% all the way down to 60%. But on aggregate, you have about 70% of women who had a known opioid use disorder diagnosis in pregnancy were screened and evaluated for hepatitis. So this is prior to universal screening recommendations during this window that we evaluated, but they had a clear risk factor for the need for screening and treatment, which was the recommendations prior to universal recommendations. So all of these women should have been screened and evaluated. So you see a 30% miss rate here in just screening and evaluation. And then if you look at the diagnosis rate, the next column, about 32% of these had evidence of an HCV diagnosis in the data. And this is just interesting. So we looked at how many had a diagnosis before the test, looking at that timing again. So how many patients presumably were coming into pregnancy with a known diagnosis, about 6.2%. And what was the relationship to how many women were getting the diagnosis after the test in the administrative data, and about 20%. So here that's just highlighting again the importance of the screening and evaluation in pregnancy, and how many more women are getting newly identified and newly diagnosed in this really critical, important window. And then if you look at this second kind of larger column, 60 days postpartum here, you see our follow-up visit rates about 10%. And it was a relatively, we counted any kind of follow-up visit that could have had anything to do with hepatitis, and only 10% of individuals followed up for a visit. And then here, let's look at the medication treatment uptake, which was less than 1%. Now, when that's 60 days postpartum, so that's universally what everyone is mandated by federal law in the United States. If you stretch that out to 6 months postpartum, you do see an uptick here in the receipt of visits for hepatitis-related diagnoses, but it continues to be abysmal initiation of treatment medication around 2.6%. And this is just kind of a more visual representation of the care cascade. So on the left-hand double bar, so the lighter shade is the 60 days, and then the darker shade is the 6 months. And the left 2 bars are testing, are predicted probabilities in adjusted analyses. The middle bars are diagnosis, predicted probabilities, and then follow up. And here, because the rates of treatment with medication were so incredibly low, we combined the receipt of medication or any follow-up visit into the same outcome variable, because rates were, incredibly low, and then differential between the 60 days and 6 months. And if you look across states, the only place that we're starting to see a difference between the 60 days and 6 months intuitively is between these follow-up periods. The more follow-up time we had, we did see a statistically significant uptake in the receipt of visits, although the overall prevalence or predicted probability continues to remain incredibly low. When you aggregate all of those together, this is for all of the states together, again, you see these same patterns, and then the only significant difference here on the right-hand side between follow-up in the different 2 time periods that we looked at. We're not doing a good job at all. And what are some, and this is just, there are multiple, but just to throw out a few gaps and barriers to consider as we go along this entire process. At the provider level, how do we communicate the need for Hep C screening and educate patients regarding risk factors for infection? So how do we communicate the need for this process, both amongst providers and to patients? And once diagnosed, how do we communicate the need to treat Hep C and educate patients regarding sequelae from untreated diseases? And how do we link patients to treatment? So is it a passive recommendation, like you need to go do this, versus an active coordination of care where we are truly facilitating the linkage to care and the uptake of treatment? And how do we create a provider workforce that is more comfortable with screening, evaluation, and providing Hep C treatment? And from a patient's perspective, how do we really how do patients prioritize Hep C infection when they may be in an unstable recovery process and they have a lot of competing demands? Where does the treatment of Hep C fall along those huge list of other things that are going on in their life? And what motivates patients to pursue treatment when they are largely asymptomatic at the time of an initial diagnosis? Like many chronic disorders, initially it may not matter to you, or you may not feel different that you have hepatitis. And how do we address that issue? And on a system level, clearly, how do we integrate a Hep C treatment into obstetric primary care and community settings? So again, this is not an exhaustive list by any means, but just some of the things we thought about after looking at for the data. But now I want to switch over to talking and hearing from Danielle Baker, who I would not call you a patient, Danielle. You are part of our family. We have known Danielle for several years and have been able to gotten the privilege to participate in the care process with her. She has two beautiful children, and it's just been a joy to participate with her in her journey. And I will let you take it from here, Danielle. But if you could help us describe your personal experience with this process and what were motivators, barriers to the process, what helped you, didn't help you as you traveled along your journey.
I mean, the one thing I really got to say is the kindness and compassion I was showed, because I had known prior that I was infected, and that wasn't always the case when I came into contact with doctors, and I was just welcomed, and it was just easy, and I felt, okay, I'm going to get treatment. I'm going to be taken care of. So that was just the best thing. And everything was streamlined in, I was already coming there for appointments, and it was just part of it, my Hep C treatment. So that was like the amazing thing with it. What was the other question you had asked me?
So in what you're speaking to a little bit, Danielle, is the integration. So you were able to receive your treatment with your substance use treatment and with your prenatal care provider. So you essentially had one location where you were able to receive care for all of these different components of your care process. Am I articulating that correctly?
Yes, which made it so simple. It was so simple. It wasn't, because I think one factor is people trying to get treatment. You don't know where to begin. Okay, you got to go to a primary doctor, then they got to send you out to an infection specialist, and then so on. So then I think it just gets, I don't even know where to start, I think that's a huge challenge. But I came there, and it was just all part of, I'm already getting substance use treatment in my prenatal care. So it was so helpful.
And then can you describe a little bit for us kind of when you received when you received the diagnosis, and the who communicated that to you? How did that occur? Just that kind of initial understanding that this was happening.
So I had received it some years prior, before I became pregnant and started coming to McGee. I mean, the first initial thing, you just feel embarrassed. I felt embarrassed, shameful, and it's nothing like, you want to talk about even with a doctor, because it wasn't always the best of situations prior. And then, I remember when I first met you, you were like so excited to have Hep C. I told my husband, I'm like, why is she so excited? It was because I was going to start the program, the treatment, that you guys had for the Plusa. And I was like, what? But, yeah. So, I mean, I just felt, it was just like, just a shame feeling, that you felt.
And how do you, and clearly the role of whoever you're interacting with, the provider or, whoever, do you feel like that would be helpful to address those fears or those concerns, and that embarrassment that you may have helped, having somebody who was willing to listen and work through that with you? Clearly, would that have been helpful?
Absolutely. Yeah. And just like, hey, we can get you treated, I mean, because I had been clean for a long time, but it's still, you just have that, feeling. So, but it was just so everybody was on the same page with me. I had you, and I had Hollis, which I don't know what her title would be, for who worked with me, but I could get a hold of her anytime. She would text me, as far as my treatment went. And it was just, it was so together for everything. Just streamlined. So.
And then help me with, help me with how you felt about the need to get treatment, urgency for treatment. What helped you feel comfortable with moving forward with treatment, and how did the need for treatment kind of factor into everything else that was going on with you?
Well, I was having my first child, and I wanted to not, I didn't want to have Hep C anymore. And I felt I was just given such a great opportunity to be a part of the Occlusive trial and stuff. And so it was my son who I was like, no, and also I didn't really know that there was treatment yet, because you had heard prior the treatments that he did have and interferon. And it was just, I had heard horror stories. So it wasn't even something I seeked in the past, because you heard those things. But then when I was presented with the opportunity to join for yours, and the new medication that was out, I was like, okay, let's do this. So, and it was only one pill a day. It was so easy. But yeah, it was my son who prompted me to want to go further with this.
Because that's really important for that's great. And what any other, and you mentioned this in your discussion regarding apprehension or concerns regarding treatment, but us able to differentiate that the newer medicines that we have available have a much less side effect profile, and those the ease of the current treatment regimens helping you become more motivated for treatment. Am I phrasing that correctly?
Yeah, absolutely. Yeah. It wasn't scary. And everything was explained to me, so clearly, and just like, this is what's, it wasn't anything that's scary. It wasn't like with all these side effects or anything, because that was the biggest thing that I was scared of, because I had not known that, that medication came out yet. So I had just known that the prior treatments.
Just to help everybody with frame of reference, you were treated around 2018, which was really when some of the direct acting antiretrovirals were coming to the scene. So that was really at that kind of critical point of transition.
Yes.
Is there anything that if you had a friend or knew somebody who had hepatitis, how would you speak with them about the need for treatment, or what would you tell that, how would you communicate to them regarding their infection and what that may mean?
I'd like to tell them, how easy the treatment is. It's nothing to be afraid of. Go forth and do it. That it's, that's the biggest thing. It's not nothing scary now. It's easy. The medication's easy. There's not these bad, nothing to fear with side effects or anything. I remember I wrote medication diary for whenever I did it, and the most I would maybe get is a headache. But yeah, it's easy. It's quick. It's mine, I think, was 3 months, so it's not long. And then you're virus free, which is amazing. So
that's, to kind of conclude on this, how do you feel now after treatment, and how different is that from pre-treatment?
I feel amazing. It's just to have that sense, I no longer have, Hep C, when I've gotten tests and everything, my virus loads are, gone and stuff. That is just the biggest relief. And just for me as a mother, just like, that's nothing that's on the back of my mind. You might not have symptoms at first, but it's a slow killer, and then later on. So my kids are going to need me later on, and I don't want to be, so sick that I can't do things for them.
That's so wonderful, Danielle. And I just want to thank you so much for speaking with us and allowing us the privilege to know you and care for you, because it's really been a wonderful process. And you are, we really all look up to you for your bravery and your courage in this process. So thank you so much.
Thank you. Thank you for having me a part of this today and everything you've done for me in the past. I truly appreciate it.
Absolutely.
Thank you so much. Thank you so much, Danielle. It's so powerful, and I think I speak for everyone in that this is really a memorable part of this webinar. So thank you so much.